afternoon and thanks for joining us. I'm Judy Simpson. Today we feature another segment of our ongoing series on cancer education in partnership with the Vermont Cancer Center at the University of Vermont and Fletcher Allen Healthcare. Our spotlight for today's segment is leukemia and lymphoma. Our expert guest is Dr. Julian Sprague of the UVM College of Medicine and Fletcher Allen. Dr. Sprague is the director of the Hematology Oncology Fellowship Program and director of the Cancer Center's Stem Cell Transplant Program. Thanks so much for being with us today.
Thanks for having me.
Let's start with some of the basics. There are a couple different kinds of blood cancers.
Yes. So I guess I would want to start by saying, where does our blood come from? And it's all made in our bone marrow, which are all of our long bones of our bodies, our skull. Anywhere you have a skeleton, there's blood products being made. In addition, you have another system in the body where the immune system matures itself. So if you get exposed to something, those cells will see the proteins of the foreign substance and make antibodies and cells to go after diseases. So in these two different compartments are places where a cancer can develop. So a leukemia typically develops in the bone marrow, where it interferes with the production of all your blood products, your white cells, your platelets, and your red cells. And that, in turn, can infect your immune system. Lymphomas, which is another whole category of cancers, can develop in the lymph nodes themselves. So that includes your spleen, and you have lymph nodes throughout your body, in your neck, in your axilla, in your groin. And you might see that there's a swelling there one day and you go, what's that about? And it could be nothing, but it could also potentially be a lymphoma. And so those are, that's the primary difference between those two cancers. They're not that common. There's probably about 10,000 cases of acute leukemia in the country in a given year. And there are also chronic forms of leukemia that would increase that number to maybe 25,000. And lymphomas tend to be on the order of about 80,000 cases a year. But by contrast, there are 3 times that many cases of breast cancer and lung cancer and the more common types of cancers.
And so, is there a way to prevent these cancers?
Like all cancers, it's probably due to multiple genetic changes that happen over time that you acquire in life. For blood cancers, there's really no screening program that we do. Just looking at a blood count really doesn't tell you much if it's normal. And an acute disease like leukemia can develop over a couple of weeks. So you can be fine, and then all of a sudden you are sick. So there's no way to really detect that in the short run.
And so what are some of the symptoms that someone might have? So
as I mentioned, if you have a lymphoma, you might notice a swelling in your lymph nodes. Don't want to scare people. It's not, something that would happen routinely. But that would be one thing. You might feel fatigue, getting some sweating at night. Really soaking your clothes so that you have to change your night clothes or your sheets might be a symptom. And just generally feeling unwell would be the symptoms, say, of a lymphoma. Leukemia would be similar symptoms, but it would happen acutely over the course of a couple of weeks. You might even think that you have a flu, but when we check people's blood counts, they can be, quite abnormal with low platelets and, anemia, and that's the source of why you're feeling poorly.
And so what happens next once you have the diagnosis? What kinds of treatments are available for folks?
So the thing that I definitely want to get across is that these are curable illnesses. And even though they might be in multiple places in your body...
It sounds pretty scary.
It is very scary. They can be still cured, unlike the typical solid tumor. If it's in multiple places, it may not be curable. But this is routinely found in leukemia and lymphomas, that they're in multiple areas, and chemotherapy is really the mainstay of treatment. So this involves coming to the clinic. You usually get an IV treatment that takes place over the course of a day or a couple of days, and then you would repeat that every 3 to 4 weeks, depending on the type of lymphoma or leukemia that it is. An acute leukemia would actually be treated initially in the hospital for a number of weeks, and then you would leave the hospital and get subsequent treatments as an outpatient.
I suppose it depends on each person, but typically how many treatments or how many months does this happen for?
So if you have a lymphoma, a typical treatment course might be 6 treatments that where you might get all of your treatment on one day, but then that's repeated every 3 weeks. So it would be 18 weeks total time of treatment. And during that time, you would get repeat imaging to look at your body to see if the lymphoma is regressing. And then afterwards, there's a aggressive imaging and surveillance of this person that goes on for a couple of years afterwards.
Is there usually a recurrence?
So lymphomas, as I mentioned, are pretty curable illnesses, and so depending on how your stage of disease is a way of prognosticating. So if you have a lower stage disease, then your chances of being cured and staying cured forever are quite good, actually, probably 60 to 70%. Higher stage disease is a little bit less. And even if they reoccur, which we are looking for aggressively during that first 2-year period, that's fixable. And we do that by giving higher doses of chemotherapy, which might require an autologous transplant, which we do at Fletcher Allen.
And so you're the director of the Cancer Center's stem cell transplant program. Tell me about that.
So that is a program in which this allows us to give us the ability to give patients a high dose of chemotherapy without killing them, essentially. So the idea is that this is a chemotherapy-sensitive disease, or you have to have a chemotherapy-sensitive disease in order for this to work.
Right.
If you give a high enough dose, then you could get rid of every last lymphoma cell. But if you do that, you're not going to allow that person's bone marrow to return to normal or come back at all. It will be suppressed forever.
So it defeats the purpose.
Right. So what we do beforehand is we save some of the person's hematopoietic stem cells, their blood-forming stem cells, in the freezer. And then we give them their high dose of therapy, and then we reinfuse them with their own stem cells, which then in about 10 days will repopulate the bone marrow.
10 days?
It's actually kind of an amazing process. You give the person their chemotherapy, and then they come in a few days later, and it's just like getting a blood transfusion of their own stem cells, and those cells will find their way back to the bone marrow. There's no surgical component to this in any way. And they set up shop there, and they regrow and start making your platelets and your white cells and your red cells again.
That's amazing.
It is amazing.
I mean, when you think about it.
Every time it happens, I'm kind of not shocked, but sort of surprised that it's happening again.
And so you're also involved with the fellowship program. Tell me a little bit about what that is.
So fellows are people who have trained in internal medicine in a residency for 3 years, and they want to go on to specialty training in hematology and oncology. There are multiple internal medicine specialties you can go into, cardiology, nephrology, pulmonology, but and we have all those programs at Fletcher Allen, but the hematology oncology program it just deals mainly with blood cancers and solid tumors. So they come, and it's a 3-year program, and we try to equally balance their training in hematology and oncology. And when they're done, they go off into, hopefully, the area that they want to go into. It actually has some subspecialization that happens. Mm-hmm. But typically people will go either into a private setting or into an academic setting. And at our program, it's about 50-50 for each one of those areas.
And we were talking earlier, and you said that you interview candidates and you try to find the best match for your facility. And you said one of the things that you look for is communication skills. Why is that?
Well, if you've ever had a cancer, you would appreciate this. I think that you want your doctor to be able to communicate to you at a level that you can understand what is going on with your disease, but also in a compassionate way, and you form a bond with this person, and I'm looking for people who are able to do that.
Is that rare?
People who do it really well, it's rare. Mm-hmm. But people who are smart can figure out how to do that well, doing it expertly is something that you figure out how to do over time.
Because I would imagine when the person is first diagnosed and you come into the doctor, they're sort of overwhelmed, not only just with all the terminology that they're hearing for the first time maybe, but also just being scared.
I think initially it's a very hard conversation, but it's one that you obviously have to have, and I like to put my fellows in that position because then they get used to doing this conversation, and they get better and better at it very quickly. And I think it's actually a key moment in the relationship between the doctor and the patient is how you handle that delivery of the news and what you're going to do about it.
Because I know you told me earlier too that you often get questions like, well, how long do I have to live? Of course, for everybody it's different, but still there are ways to handle that.
Right, and the fortunate thing of being in the hematology area is that I usually have something good to say because these are curable illnesses a lot of the time, and sometimes they're not, and so you have to be able to communicate that well too, so you don't have unrealistic expectations. But people can do quite well, and treatments have changed dramatically enough that often people can go along and live their lives and do fun things while they're getting treated.
Yeah, we talked about stem cell transplants, but what are some of the other advancements that you've seen or that you anticipate?
So, since I was a fellow, which wasn't that long ago, I'm not going to say how long ago it was, there have been a lot more advances in targeted therapy, and this is different from traditional chemotherapy. Traditional chemotherapy is you get a drug that essentially blocks cells from reproducing, but it does it in every cell. And so that's why you get a lot more side effects. And targeted therapy is really more for specific types of cancers, specific receptors on cells and specific cancers. And that leads to lower side effects, potentially lower side effects, and really a better way of getting through your therapy, and also potentially more effective. So what some of the new advances over the years have been antibodies, as opposed to chemicals that interact with your DNA, but antibodies that actually go to the cells that you're worried about and kill those directly. And so there are more and more of those types of treatments coming online, which is very exciting and is way more tolerable than previous therapies.
And so tell me a little bit too about not only dealing with the patients, but also the patient's family, because I would imagine they're pretty key in recovery.
Cancer treatment is very complicated, and just the logistics of it is very difficult. So if you live even a little bit farther away, you got to have somebody bring you. You got to have somebody bring you home. You have to have somebody with you at home, because if you're not feeling well, you're not going to be cooking yourself meals, doing all the normal household things that you would do. It really requires a fair amount of support from your family, and you can't just have one person doing it, because that's, would be
full-time job.
It is a full-time job. And I really feel for a lot of people who come up with this diagnosis who don't really have that support level, because it's very hard for them, and sometimes it just makes it not possible to do treatments that could potentially be curative or life-prolonging. You got to have that support. It's very tough.
And so I want to go back to a little bit about the fellowship program. Once that match is made and you have your new fellows in, you said it's a 3-year process that they'll be with you? And so what do they learn in that 3 years besides communication?
Well, for the first time, have really been able to concentrate in this small area. So in internal medicine, which is their previous training, it's a very general, everything about the body, they are supposed to know. Now they are concentrating on an area that's a little bit narrower, but they soon discover that it's actually even more full of information than they ever possibly could realize. So hopefully they're going to learn, more than the basics of treating hematologic cancers. They're going to learn more than the basics for treating solid tumors, and they're going to learn about how to think about ways of investigating how you would understand how a cancer works or how a treatment works, there's a whole research component to our program, as there are in other fellowship programs. And so when they leave, they will not only know how to treat people, but they are going to know how to investigate. When they don't know how to treat someone, they're going to be able to find the best therapy for them.
Well, Dr. Sprague, I want to thank you so much for joining us today.
Thanks for having me.
That's our program for today. I'm Judy Simpson. We'll see you again next time on Across the Fence.
For a video copy of today's program, call toll-free 1-888-ATF-3430. Across the Fence is brought to you as a public service by University of Vermont Extension and WCAX-TV.